This is Dr. Marnie Peterson. I'm the Outreach Coordinator for the Antimicrobial Stewardship Project, which was launched last year by the Center for Infectious Disease Research and Policy at the University of Minnesota. It's my pleasure to welcome our participants to today's webinar, Expanding Antimicrobial Stewardship in Long-Term Care, with Dr. Kavita Trivedi. A little bit of background about Dr. Trivedi. She's the founder of Trivedi Consultants and is an adjunct clinical professor of medicine at Stanford University School of Medicine. Since 2011, she's been an attending physician in the emergency department in San Francisco Veterans Administration Medical Center, and she's also been actively involved in the Society for Healthcare Epidemiology of America, SHEA. Previously, Dr. Trivedi was the Public Health Medical Officer of the Healthcare Associated Infections Program at the California Department of Public Health, where she created, managed, and led the California Antimicrobial Stewardship Program initiative. She's the author of many publications related to preventing antimicrobial resistance and promoting antimicrobial stewardship. Thank you, Dr. Trivedi, and participants for joining us today. I would like to just give you a few instructions. At any time during the webinar, our participants are encouraged to submit questions or comments in writing via the WebEx chat box located at the bottom right corner of your screen. When typing in the questions, please make sure to send your questions to all panelists. And then we will have time at the end of the webinar for further discussion of your questions. So with that, Dr. Trivedi, I'd like to welcome you to our webinar, and we're ready for you to begin.
Great. Thanks, Marnie. I hope everybody can hear me okay. So today's topic is expanding antimicrobial stewardship into long-term care. And I'm sure many of you are either considering this or are grappling with how to do this. So we're going to give you hopefully some practical ways of expanding your program into the long-term care sector. I'm going to start off by talking about the rationale for antibiotic optimization. I'm sure many of you are well versed in this topic, but we'll just make sure we're kind of all on the same page. Then I'll talk about the current regulatory messages and requirements regarding antibiotic use in long-term care. And finally, we'll talk about some examples that I think are really useful from the long-term care setting. As you all are very well aware, the healthcare continuum has really expanded, especially in the last 20 to 30 years. We used to provide care simply in hospitals, which are the acute care facilities depicted here. But now we have home care, we have long-term care, we have ambulatory care. So we have a lot of different places that we provide care, and there are different expectations in each of these settings with the care that we provide. We can't really provide exactly the same care in every single setting since the expectations are different. So I'm going to focus really on acute care hospitals and long-term care facilities today in our discussion, not really going to talk about home care or ambulatory care. So you may or may not know there are over 15,000 nursing homes in the United States. Over 4 million individuals receive care in these nursing homes every year. And these homes do have a fairly large number of infections that they deal with on a regular basis. On any single day, 5% of the residents in a nursing home likely have some sort of infection. The other thing to note is that over 21% of the population will be over 65 years of age by 2040. So approximately a fifth of the U.S. population may be living in long-term care facilities in the next 35 years. So it's really important that we address the kind of care that is being given in long-term care facilities. As you all probably know as well, resistant organisms are quite common in long-term care facilities, and we'll talk about the reasons why. But there is a lot of infection occurring in long-term care facilities, but there's also quite a bit of colonization occurring in long-term care facilities as well. And unfortunately, often there is not a good understanding of the difference between infection and colonization. In in one study, over 50% of patients that were being discharged from acute care hospitals were going to long-term care facilities with resistant organisms. So I think the big thing to note about this is that one of the reasons that we have so much resistance in long-term care facilities is because the sickest patients that have the resistant organisms are not going home. They're going to post-acute care, which includes long-term care facilities. So we shouldn't be surprised that we have such a high number of resistant organisms in long-term care. But we often find this struggle, and for those of you that work in acute care hospitals, you know that there is this struggle between who and where the resistant organisms come from, right? Is it coming from acute care? Is it coming from post-acute care? And I think this image really depicts that quite well. These are two rams that are fighting, and sometimes we're arguing about where the organisms originated and where they're coming from. So I want to mention this study that was published many years ago, about 15 years ago, in the Journal of the American Geriatric Society. And I really like this study because what they did was they went into a long-term care facility and they ended up swabbing all of the residents in the long-term care facility looking for any resistance. And this is mostly colonization that they were finding. So they looked at everyone's rectum, so that's the RG there, and they looked at intropharyngeal swabbing as well. And what they found, what I've highlighted in red here, is that the rates of colonization for these various resistant organisms is actually quite high. So you can see for MRSA, methicillin-resistant Staph aureus, 21% of the residents were actually colonized with MRSA. In terms of ESBL producing Klebsiella pneumoniae, between 14 and 17% of residents were colonized with this particular gram-negative, and up to 25% of residents actually had ESBL producing E. coli. So resistant organisms are common in long-term care facilities, and we're seeing a lot of that occurring in terms of colonization in this setting. So again, why do we have high rates of multi-drug resistant organisms in long-term care settings? I've already mentioned the first one. There's frequent transfer from acute care hospitals of these sicker patients that need more aggressive care, so they end up going to long-term care facilities. We also have high rates of horizontal transmission of resistant organisms occurring in long-term care facilities, given the sicker patients that are now in these settings. And we have widespread and often inappropriate use of antimicrobials, and this is quite common and rampant in long-term care facilities. So this is also the same study that we just looked at previously from the Journal of the Journal of American Geriatric Society in 2004, where they looked at those residents that ended up being colonized with those resistant organisms. And what's really fascinating about this study is they looked at the frequency that these patients had received antibiotics in the hospital that then made them develop the colonization with the resistant organism in the long-term care facility. So let me just walk you through this here. So if the resident had received levofloxacin in the hospital, okay, they were 1.6 times more likely to develop MRSA in the nursing home. If they had received the third-generation cephalosporin in the hospital, they were 2 times more likely to develop MRSA in the nursing home. And this was true for many of the resistant organisms they were looking at. So I highlight this study only to show you that what happens in the hospital affects the development of resistance that occurs in the nursing home. So again, going back to that image of the two rams fighting, it really is kind of a ridiculous conversation, because what we do in the nursing home affects the patients when they go to the hospital, and clearly what happens in the hospital affects the patients when they go, with the residents when they go back to the nursing home. So I want to mention the issue of horizontal transmission. Long-term care facilities can promote antimicrobial resistant infections and transmission because of some of these reasons I have listed here on the slide. Invasive devices and procedures are much more common in long-term care facilities than they were in the past. If any of you actually do work in a long-term care facility, you know there are more central lines there. There is now more chronic respiratory therapy. You often have subacute units where residents are actually on ventilators. And from my perspective, if you have not gone to a long-term care facility, a nursing home, you really should, because you will be surprised that those residents are actually not in a hospital. 15, 20 years ago, they would have been in a hospital. There are now more feeding tubes in nursing homes. More residents are requiring dialysis, and more residents are able to get IV antibiotics. So these invasive devices and procedures all also increase the risk of developing resistant infections. As I mentioned before, the population has really changed. There are more acute and subacute patients that were treated previously in hospitals that are now treated in nursing homes. And unfortunately, often the staff have not been given the appropriate education to deal with these more acutely ill residents. And lastly, we have this problem with the changing infection control provider without a lot of expertise. So in many nursing homes, the infection control nurse often is kind of a hot potato position and changes from person to person in the facility, and really isn't somebody who has a lot of expertise and very often. So they're not able to promote kind of the best ways of preventing transmission from resident to resident. I just want to briefly mention this study done in Ontario in 2010, and it looks like we might have some colleagues from Ontario that are participating in the webinar. Over a single year, 75% of residents in long-term care facilities in Ontario received an antibiotic course. 44% of those antibiotic courses exceeded 7 days in length. So again, lots of antibiotic use happening in long-term care facilities. 2,600 different physicians were prescribing these antibiotics in these long-term care facilities in Ontario, and only a portion of the prescribers were responsible for a large number of the antibiotic courses. So we did have a lot of high prescribers. 21% of the prescribers were responsible for about 80% of the antibiotic courses. And a subset of the providers, in this study, 145 prescribers were identified as long-duration prescribers. So they typically prescribed antibiotics for a longer period of time, around 11 and a half days. So this study nicely showed us that we do have a lot of antibiotic use happening in long-term care facilities, and we may be able to focus on a subset of the prescribers to really affect some change in this setting. To continue with the study, residents in the high antibiotic use nursing homes had a 24% increased risk of antibiotic-related complications. So if they were exposed to more antibiotics, they were having more adverse events. And these adverse events included hospitalization or ED visits, indwelling medical devices, functional dependence, and incontinence. So very real problems for especially debilitated long-term care facility residents who have been unnecessarily exposed to antibiotic use. So in many of our studies, we have assessed that 25 to 75% of the systemic antimicrobial use occurring in long-term care facilities and up to 60% of topical antimicrobial use in the long-term care facility is considered inappropriate and unnecessary. So it's a really high number. I would say for most of you working in long-term care, the majority of antibiotic use occurring in the long-term care setting is most likely inappropriate. And I'll show you some data to back that up. So as already mentioned, I am formerly a public health medical officer in the California Department of Health. And one of the first studies I was involved with was a study in a long-term care facility back in 2010 in California. And this is published if you're interested in learning more about this with the reference below. So we were called into this long-term care facility because the hospital that transferred patients back and forth from this long-term care facility was concerned about the rate of Acinetobacter baumannii that was occurring in the residents from this facility. So as the public health department, we went into this facility with the local health department and conducted this point prevalence study. So we went in and we did something similar to that, that JAGS article that I showed you earlier. We did a colonization study, point prevalence of every single patient in the every single resident of the nursing home. And I will note that this nursing home did also have a subacute unit. So there were, there were very sick patients also on vents in this nursing home. So our baseline colonization rate for Acinetobacter baumannii in this particular nursing home was 19%. So about a fifth of these residents were colonized with Acinetobacter. When we looked specifically at susceptibility patterns, we were able to find that 36% of those colonized residents actually had multi-drug resistance. So they were resistant to cephalosporins, fluoroquinolones, and aminoglycosides based on our definition. So because we're the public health department, we're able to do these things. We implemented a strict infection control policy and made sure that this facility was compliant with this policy and had really good practices. We had an infection control nurse from the state health department go into this facility once a week and ensure hand hygiene was properly being implemented. Cohorting was happening, so all the residents that were colonized were cohorted both by healthcare provider as well as the place that they were in the facility. They also had contact precautions in place for all of those residents as well. We also enhanced environmental cleaning. And after 6 months of doing both of those things, so really affecting infection control and kind of getting it to the best point that we possibly could, and also enhancing environmental cleaning, our follow-up colonization rate, unfortunately, was the same, was 19%. So at first, we were kind of disheartened by those results, but then when we looked more, we thought, well, maybe we didn't have any horizontal transmission occurring, and those 19% of residents that were colonized were the same. Unfortunately, 36% of the residents that were negative on the first study were now positive on the second study. So we actually did show horizontal transmission occurring in the setting of this study. And then on top of it, we were actually able to show that 71% of these newly colonized residents now were multi-drug resistant. So not only did we have horizontal transmission occur during this study, we also had the susceptibility patterns worsen. So because of our findings of that last study, what I usually mention here, and I usually have a slide about it, but I think I took it out, is, to affect antimicrobial resistance, there are kind of three arms, in my opinion. One is infection control, one is environmental cleaning, and the last is antibiotic use. And so the thing that we did not affect in that last study was we didn't touch the use of antibiotics. So we actually went back in after getting a grant. We went back into this nursing home and some others to really study the use of antibiotics. And so I'm just going to show you the beginning of this study. This is our baseline evaluation of these 4 nursing homes, including the one that we'd been in before. We just decided to focus on UTI. As probably many of you know, UTI is like the most common syndrome, infectious syndrome in nursing homes to address. We looked at 104 residents in this baseline study that were treated for UTI. And I just want to show you that only 8 of them met criteria for UTI. So although 104 residents in these nursing homes are being treated for UTI, only 8% of them met criteria for UTI. So although most patients on UTI therapy did not meet the consensus criteria for UTI, any positive urine cultures did lead to antibiotic treatment. And a lot of the treatment was also nurse-driven. So this was really important information for us to know and for us to be able to kind of promote that positive urine cultures automatically led to antibiotic therapy, even if it was not appropriate. So we've talked a lot about the antibiotic usage in nursing homes, and I just want to quickly mention that our hospital colleagues, I'm sure we have some on the line as well, we're not doing a great job in hospitals either. From this study back in 2012, we have estimated that about 30% of antimicrobial use in the acute care setting is either inappropriate or suboptimal. This is a graph from that study, and they just show 5 different hospitals. This is a prospective study and post-prescription review of antibiotic use at these 5 hospitals, which are, I believe, all academic medical centers. And you can see the gray parts of the bars are antibiotic use that is unjustified, and it goes anywhere from 13% to 39% in these 5, very highly acclaimed institutions. So there is a lot of unnecessary use occurring in hospitals as well, which we're trying to affect also. The reasons for unnecessary use in the hospitals were interesting. Reasons for a modified regimen for antibiotic use. The most common reason for that was that a more appropriate agent was available. So they were not ensuring that patients were on kind of the best or most appropriate regimen for their particular infection. And there were a lot of instances where even though the antibiotics should have been stopped, it continued. So there were 28% of situations where antibiotics were continued, but they were actually no longer needed. So I don't want to leave out our hospital colleagues. We are trying to do a lot in the hospital setting as well. It's not all just needed in the long-term care setting. So with all that information, what can we do? We can sit around and we can wait for new antibiotics. Probably not a good idea. I didn't show you earlier, but I'm sure you are aware, we really do not have any new antibiotics, new mechanisms for antibiotics that are coming out on the market anytime soon. So we really can't sit around and wait for new antibiotics to bail us out of this particular resistant problem. The next thing is the programmatic approach. Can we optimize the use of antimicrobials? I would say absolutely. The next is the point of care approach. Can we teach prescribers to change their views and habits? This is also very much a part of what we're trying to do across the country, and takes a little more time to teach prescribers to change their views and habits, but definitely worthwhile. And lastly, a regulatory requirement. Can we just make, can we use the carrot and the stick approach, and can we make prescribers change their use of antimicrobials? And I would say we're trying to do portions of all of those 3 bottom options. So it is widely accepted, as you probably all know, in the hospital and acute care setting if we are able to improve antimicrobial use, we can improve resistance patterns, we can decrease patient toxicities, and we can secondarily decrease healthcare costs. I think in the long-term care setting, there is limited literature and fewer studies to help us see that we need to improve the use of antimicrobials in that setting. But I think it's pretty clear that working together across the healthcare continuum may actually be the ideal approach, right? So those of you that work in a hospital that have nursing home residents that are transferred back and forth from your hospital, the most ideal approach may be to work with those nursing homes that you share patients with, and vice versa, the nursing home working with the hospital to maximize resources and efforts. That may actually be ideal, and I'll give you some examples of that later in the presentation. So antimicrobial stewardship programs is how we are trying to affect the use of antimicrobials in all of these settings, in all of the healthcare continuum. Just to define what an ASP is, this is a program with coordinated interventions to improve and measure the appropriate use of antimicrobials by promoting the selection of the optimal drug regimen, dose, duration of therapy, and route of administration. So these are all aspects of making sure that we use antibiotics appropriately. And just to mention again, our objectives with this program are not to limit and restrict the use of antibiotics by providers, because that's not what we're trying to do. We're actually trying to minimize acquired resistance, improve patient outcomes and toxicities, and reduce treatment costs. All things I'm sure you are very well aware. So regulatory messages. Let's get into some of the regulatory messages. And again, I'm really going to focus on regulatory messages in the long-term care setting. So as you are aware, or you may not be aware, actually, this is something that was brought to my attention many years ago, and I think slipped through slip through the fingers of many of us, really. The Center for Medicare and Medicaid Services, CMS, along with Department of HHS, did have this publication of interpretive guidelines for long-term care facilities that was effective back in September of 2009. And to my knowledge, this is actually the first regulatory guidance from the federal government or any state government, actually, regarding the use of antibiotics. And if you look at this very long document, it states that it is the physician's responsibility to prescribe appropriate antibiotics and to establish the indication for use of specific medications. As part of the medication regimen review, the consultant pharmacist can assist with the oversight by identifying antibiotics prescribed for resistant organisms or for situations with questionable indications and reporting such findings. So I see there's some questions in the chat box about pharmacists. So I'm going to get to your questions at the end, but I just want to mention here that there is a consultant pharmacist that comes into every single nursing home once a month. I believe that is required. And this interpretive guideline actually allowed the consultant pharmacist to not only look at antipsychotic medications, which is primarily what they had been focusing on the last 10, 20 years in the nursing home, but they're also can be directed to look at antibiotic prescribing as well. And they're able to kind of look at the indications and report that back to the physician. So this, again, is the first regulatory guidance we had from the federal government, certainly, and state governments about the use of antibiotics in any healthcare setting. So it's really very notable that that was already on the radar of CMS. Existing regulations promoting antibiotic stewardship in nursing homes. So I want to mention a couple of F-tags that are already in place that do help promote antibiotic stewardship in nursing homes. So the first one is F-tag 441, which is the infection control F-tag that mentions performing antibiotic reviews. The next one is F-tag 329, which are necessary drugs. So this one really is about the adverse drug events that occurred due to many different agents, including antibiotics. The next F-tag is 332, 333, medication errors to reduce preventable errors and adverse events. The last one is the drug regimen review, which again outlines the role of a pharmacist in scheduled reviews of medication use in high-risk residents. Again, you can ask your pharmacist to really focus on this. I'm kind of going in chronological order. The next thing that we saw was this report that came out of the White House back in 2014. This was the PCAST report, the President's Council of Advisors on Science and Technology, and I had the pleasure of serving on one of the work groups for this report. So one of the recommendations that was made out of this report was to recommend improved antimicrobial stewardship in healthcare, and the carrot and the stick phenomenon was recommended here that CMS should use reimbursement incentives to drive antibiotic stewardship. So they did recommend that this occur both for hospitals and critical access hospitals, as well as long-term care facility and nursing home facilities. So nursing home facilities were not exempt from this recommendation. The next thing we saw in terms of regulatory messages was this Senate bill from California, which was authored by Senator Jerry Hill in San Mateo County. This is Senate Bill 361, which has now been incorporated and is part of our the Health and Safety Code in California and is currently in effect. So this part of the Health and Safety Code requires that on or before January 1st, 2017, each skilled nursing facility in California shall adopt and implement an antimicrobial stewardship policy that is consistent with antimicrobial stewardship guidelines developed by the CDC, CMS, SHEA, the Society for Healthcare Epidemiology of America, or any similar recognized professional organization. So for those of you in California, I'm sure you're aware of this, but just so you know, this is in effect right now, that each nursing home in California should have some sort of antimicrobial stewardship policy and guideline in place. And I will talk about the CDC guidance in a moment. Just to let you know, we have about 1,200 nursing homes in California, so it is this bill does affect a good chunk of the nursing homes throughout the country. And then the most recent regulatory kind of movement was that this new finalized CMS rule, and this took into account a lot of reform requirements for long-term care facilities, and it was finalized in September of 2016. It highlights improvements in care, safety, and consumer protections for long-term care facility residents. So I just want to note that they updated the infection prevention and control program, including requiring an infection prevention and control officer and an antibiotic stewardship program that includes antibiotic use protocols and a system for monitoring antibiotic use. So again, just so you realize, this is now a condition of participation, okay? So the rule went into effect November 28, 2016, and they have thankfully developed a phased-in implementation guidance. There's phase 1 by November 28, 2016, which I'll mention in a second, phase 2 by the year after this November 2017, and then phase 3 by November 28, 2019. So I wanted to highlight just a couple of the things that they changed in terms of these F tags. A pharmacist is required to review the resident's medical record coincident with drug regimen review when the resident is new to the facility, a prior resident returns or is transferred from a hospital, and during each monthly drug regimen review. So they're going to be looking at psychotropic drugs, as I already mentioned, as well as antibiotics. So they are absolutely supposed to be looking at antibiotics as well, and you should be directing them to make sure that that is happening. In terms of the F tag for the infection control, the facilities, as I already mentioned, the facilities infection prevention and control provider must also include an antibiotic stewardship program that includes antibiotic use protocols and systems for monitoring antibiotic use. So this also should be happening. Just so you're aware, these other F tags, the medical chart review, should be implemented in phase 2, and the antibiotic stewardship should be also implemented in phase 2. So just to go back to my slide here, phase 2 is by November 28, 2017. So most of the antibiotic stewardship requirements are required in hospitals, in nursing homes as a condition of participation as of November 28, 2017. So we have a few more months before that goes into place. In terms of funding support, I always get this question, so I stuck this slide in. Even CMS admits this new wave of regulations will bring with it hundreds of millions in additional costs at any new funding streams, okay? So nursing homes are really required to put these new regulations into effect on their own without additional funding. All right, so now I'm going to go into ASP implementation. If okay with Carlos and Marnie, I'm just going to address the questions at the end. Okay, ASP implementation. So there are differences in implementing these programs in hospitals and in long-term care facilities, right? As you all know, many hospitals have developed stewardship programs due to the increasing prevalence of healthcare-associated infections, coupled with decreased reimbursement and public reporting, and also, of course, the problem with the lack of new antibiotics in development or in the pipeline. Long-term care facilities have been slower to adopt antibiotic stewardship programs due to lack of necessary personnel, right? They often do not have an infection preventionist in their nursing home that's really focused on just infection prevention. They often don't have an ID physician or a physician that's well-versed in antibiotic stewardship. They often don't have additional funding. And there really, unfortunately, are a paucity of well-validated strategies in the nursing home setting. So I want to talk about quickly who should be involved with your antibiotic stewardship programs in your nursing home. Essentially everybody, right? Pharmacy should be involved. I think getting those consultant pharmacists to engage in the antibiotic stewardship program is really key if you can get them to do that. Microbiology, whoever is providing your laboratory services, you need to get them on board with the antibiotic stewardship program as well. You may not have an infectious diseases division at your or any ID kind of trained person at your nursing home. You may not. If you don't, there are various ways to get ID people that are trained in antibiotic stewardship involved with your stewardship program in your nursing home. You can go to your local hospital to help you with that. You can You can use telemedicine to get an ID provider. There are many services now of ID providers focusing on antibiotic stewardship services to nursing homes and hospitals, and especially in rural settings. You have to get your nursing home leadership involved in the antibiotic stewardship program. Any patient safety groups need to be involved with your antibiotic stewardship program. Again, this is really a patient safety program. If you have a P&T committee, a pharmacy and therapeutics committee, they should definitely be involved. Any IT system group should be involved with your antibiotic stewardship program. I know many nursing homes are now starting to look at EMRs or have EMRs, and they also should be very well involved with how to best implement your antibiotic stewardship program. And then last but definitely not least, infection control. And these nursing homes, often the infection control provider, which is often a nurse, is the only person that is implementing the antibiotic stewardship program. So infection control should absolutely be central in the nursing home setting. So how do you choose a strategy? How do you decide where you start with the stewardship program? In my opinion, it's really facility dependent. It depends on the problems in your facility. It depends on the number of beds you have. It depends on the acuity of care that you are trying to service. It depends on which kind of personnel is available. It depends on which personnel is interested. You may happen to have a LVN in your nursing home who has had a personal relationship with somebody who had C. diff and who got C. diff based on antibiotics that were unnecessary. You have to see who in your facility is the right spokesperson to kind of get people on board with antibiotic stewardship. You obviously will have to look at funding. What kind of funds do you have available to help with this program? Now that this is a conditional participation, funding should be less of an issue. You should be able to get more funding from your administration for this particular program. It also should be woven into whatever pharmacy funds you have and infection control funds you have. Pharmacy support. There are some consultant pharmacists that are really excited about stewardship, others that are not interested in changing what they've been doing the last 20 years. You have to figure out which pharmacists and how to get them involved with your stewardship program. Electronic systems we've already talked about, and laboratory support. And I just want to mention laboratory support here. Laboratory support is very, very, very helpful. And many of the laboratories that are supporting long-term care facilities can develop antibiograms and develop a lot of tools that are useful for the antibiotic stewardship program. So I would really advocate for getting the laboratories involved. Next, I want to mention kind of different strategies and how you decide which one to use. So this is a really wonderful paper published by Phil Smith and his colleagues in the Annals of Long-Term Care, which is easily available online and was published. This particular article was published back in 2011. And what they did was they talked about kind of strategy hierarchy in the long-term care facility for stewardship. So at the bottom of your screen is kind of the strategies that are least intrusive, require the least amount of expertise, effort, and expense. And at the top of your screen, in the red, orange and red, are the most intrusive strategies requiring most expertise, effort, and expense. So at the bottom of the screen, passive monitoring. This is just measuring types and quantities of antibiotics used in the facility, looking at your antibiogram, what antimicrobial resistance patterns are present in your facility. I think a lot of times providers are not aware of the differences in sensitivity reports between long-term care facilities, and many of our providers practice at many different facilities all at once. So they need to be aware of the differences in susceptibility patterns in these different facilities. Education. Classes or training sessions regarding antibiotic resistance, just making people aware, I think is really important. Small group sessions with antibiotic prescribers. Maybe you can get an ID physician or a physician well-versed in antibiotic stewardship to come and talk to your prescribers over lunch, have some case discussions about when it's appropriate to give antibiotics or not. And then we get a little more intrusive, right? The front-end approach, which is really developing guidelines, treatment algorithms, having a formulary, antimicrobial order forms that really help providers choose the correct antibiotic for your facility. That's kind of the front-end approach, which is a little more passive direction of antibiotic selection. And then the next is the front-end approach, which is more active direction of antibiotic selection, where you actually, require different loopholes that the prescriber has to jump through in order to prescribe certain antibiotics, right? So you have pre-authorization of antibiotics based on predetermined criteria. You review cases and provide immediate feedback on the choice of antibiotics right when the antibiotic is first initiated. And then the approach that is the most intrusive is the back-end approach, where individual cases are concurrently reviewed for appropriateness, usually by an expert, with feedback back to the provider. Individuals use data with comparators and benchmarks to provide prescribers kind of more better recommendations and regarding appropriate use. So that's kind of the more back-end approach and requires kind of the most expertise, effort, and expense. So this may help you determine which strategy works best for your particular facility. So I want to mention the CDC core elements of antibiotic stewardship. This is a document that came out a couple of years ago. Yes, a couple of years ago, back in October of 2015, which highlights some elements of antibiotic stewardship programs in nursing homes. And I just want to note that this is an adaptation of core elements for the hospital ASPs. But what we saw in this document, which I think is really well done, is that the nursing homes are encouraged to work in a stepwise fashion, implementing one or two activities to start and gradually adding new strategies from each element over time. So don't get overwhelmed with the fact that this is something that you have to do all at once. So these are the core elements, the CDC core elements of antibiotic stewardship. The first is leadership commitment, really getting your leadership behind your program. And again, because of recent CMS rules, I would hope that the leadership commitment piece would be a little more easy to obtain now that it is a condition of participation. Accountability, determining who is going to be accountable for your stewardship program, the physician, the nurse, and pharmacy lead. I would say all three of those people are extremely important to identify, especially in the nursing home. I think oftentimes in hospitals we don't focus on the nurses, but in nursing homes the nurses are incredibly important for these programs. So having a physician lead backing up what's happening, a nursing lead and a pharmacy lead is extremely useful. Finding your drug expertise is also useful. Who is going to provide expertise on, which antibiotic and how the antibiotic should be used in terms of duration, dose, all of that. You can often find the drug expert within your pharmacist if they're interested. You can also find the drug expert within an ID colleague at the local hospital. There are many ways of trying to get that drug expertise. Action, we already talked about strategies, so implementing at least one policy or practice is what's recommended. Again, this action can be something passive, but action, the piece of action is very important. Tracking, monitoring at least one process and at least one outcome measure is the ideal. So, if this means starting with an antibiogram where you just see what's happening in terms of susceptibility patterns, looking at number of urine cultures, looking at antibiotic use, you can just start with tracking, and that can lead to some action, which could simply be education, could be your first action. Reporting. So reporting is also really important. I think it's important for the person who is leading the stewardship effort in the nursing home to give regular feedback back to the nurses, back to the staff, back to the prescribers, so that people understand how their changing of antibiotic use is actually changing what's happening in the facility. And I think you actually can see pretty quickly changes in susceptibility patterns based on, small tweaks in what is happening at the facility level. Education, again, is super important, and it is the seventh core element, but probably, should be the first, second, and third, really important. Educating clinicians, nursing staff, residents, and families. And I just want to highlight the resident and family portion of this. It is very important to educate your residents and your families about what you're doing in terms of antibiotic stewardship. I've seen some nursing homes that have incorporated antibiotic stewardship guidelines or information into their welcome packet, so residents understand from the get-go this is a new program that you have bought into, being that you're going to be at this facility. And I think having some of those discussions with resident and family members before you are in the throes of an infection is very important. Lastly, I just want to mention that we recently published, not recently now, wow, almost a year ago, the SHEA IDSA ASP implementation guidelines, and there is one specific paragraph focused on nursing homes. So we do suggest that in nursing homes, in skilled nursing facilities, that we implement antimicrobial stewardship strategies to decrease unnecessary use of antimicrobials and improve clinical outcomes. So from a professional society standpoint, and from an evidence standpoint, this is definitely a good practice recommendation. And we do talk a little bit about how to do that. So we talk about in this comment, implementing ASPs at nursing homes and skilled nursing facilities is important and must involve the point of care provider. So we're really talking about nurses here to be successful. The traditional physician pharmacist team that we employ in hospitals might not be available on site, but the nurses are there all the time and should be educated on various strategies to implement antimicrobial stewardship. And then we can also obtain infectious diseases expertise through things like telemedicine. So you might want to read that one paragraph in this document if you want more information. All right, now I'm going to blow through some examples because I want to get through to some of your questions that have come in. So education can work to reduce treatment of asymptomatic bacteria. So I didn't get a chance to really talk about asymptomatic bacteria, but I did mention earlier that UTI is the syndrome most commonly prescribed antibiotics for in the long-term care facility. And asymptomatic bacteria is often the syndrome that's being prescribed antibiotics for. And you do not need to prescribe antibiotics for asymptomatic bacteria except for cases where you have a pregnant second trimester woman, or you have just had a patient that has undergone some sort of urologic procedure, like a TURP or something. Otherwise, just because you have a positive urine culture does not mean you need to treat that positive urine culture. And this is a really simple concept. I think that if we can get through to many of our nursing homes, we will really reduce the use of antibiotics in many of our nursing homes. So this is a study done in Cleveland with Kurt Donsky's group many years ago in a long-term care facility there. And all they did was simply had some education of the nurses for when it was appropriate to get a urine culture, and for the doctors when it was appropriate to treat the positive urine culture. So essentially, they educated the doctors on what is the syndrome of asymptomatic bacteria. So this study looked at 3 months pre-intervention and 7 to 30 months post-intervention. And you can see that the number of total urine cultures dropped from 3 months pre-intervention to 30 months post-intervention significantly. The number of inappropriate cultures decreased as well. And then the number of patients or residents that were treated for asymptomatic bacteria also decreased. So because of this, they were actually able to reduce the amount of antimicrobial days of therapy per 1,000 patient days. So they went from 167 days of therapy to 109 days of therapy per 1,000 patient days. And this is simply education with the nurses on the urine cultures and with the doctors on when it was appropriate to treat the urine cultures. So really simple study with a nice decrease in antimicrobial usage. So I already mentioned this, and I just want to close this loop here. As I said, back in 2011 and 12, we did implement a formal stewardship program in 3 nursing homes actually it was 4 nursing homes in California. And what we did this with a ID pharmacist and an ID physician providing post-prescriptive review and feedback. So this is kind of the most intrusive strategy, if you will, on improving antibiotic use. Some of our results in the nursing home were that we did make some recommendations on improving antibiotic use in 43 cases, and a minimum of them were actually accepted. And there were various reasons for why that was the case. I think a lot of the providers really still felt like those patients and those residents needed to be on antibiotics. And the other thing is we only went in once a week to provide these recommendations, so sometimes our recommendations were not made in a timely fashion. Recommendations were not made in 61 cases due to 20 of the residents on appropriate therapy and 41 who completed therapy between evaluations. And just so you know, with this antibiotic stewardship program, this ideal stewardship program, this long-term care facility, none of the residents whose recommendations were accepted experienced fever, leukocytosis, or escalation of therapy or death at 30 days. So they did quite well if the recommendations were accepted. So you can see here from our study, from pre-intervention to post-intervention, we did have a nice decrease in the number of antibiotic starts and the number of antibiotic starts for UTI in particular. Unfortunately, this was not statistically significant, but you can see that we did have a decrease in use across all 4 of our facilities. And lastly, and I wish I had more time to go into more examples, but I do want to mention this kind of older study as well, but I think a really lovely study done in New York State, which focused on using hospital expertise to develop stewardship programs in long-term care facilities. Greater New York Hospital Association, United Hospital Fund, and the New York State Department of Health put together this program where 3 hospitals worked with 3 nursing homes to establish stewardship programs using their existing personnel through collaboration with acute care hospitals and partners. So they developed pilot tools and materials for ASP implementation and development. And unfortunately, I don't have the link here, but these tools are available online. So all of the nursing homes identified inappropriate treatment of asymptomatic bacteriuria as their main focus. 2 out of the 3 of the nursing homes reported qualitative improvement with developing this program. And successful implementation of the stewardship program was associated with a motivated team, support from the administration and medical leadership, collaboration with their hospital partner. I think this is really key for many nursing homes, and the ability to provide antimicrobial use and resistance data. So they were really able to develop, I didn't say this, but this all happened within 8 months. They were able to develop these pretty substantial antibiotic stewardship programs in just 8 months by utilizing expertise from their hospitals that they share patients with. I think that's a really, really nice example that we can all potentially emulate. All right, so in conclusion, I hope I've convinced you that ASPs are essential in long-term care facilities because of the high rates of resistance, variable infection control, expertise, and implementation, and the predominantly overuse of antimicrobials in this setting. I think that's pretty clear that we have an overuse problem in the long-term care setting with antibiotics. CMS has established regulatory guidance to prioritize optimizing antimicrobials. California now requires stewardship programs in every nursing home, and CMS now has made this a condition of participation such that every single nursing home in the United States should have a stewardship program by the end of this year in order to comply and continue getting funding from CMS. We do acknowledge the implementation of stewardship programs is very difficult given there is this elderly population and it's complex to deal with them, especially when they can't communicate, but also because guidelines, expertise, and resources are really limited in the nursing home setting. However, I really think that stewardship programs that do not look like ones in hospitals, but are still effective, can be implemented in long-term care facilities. the criteria such as a syndromic approach may be a low-hanging fruit. So maybe just focusing on UTI or pneumonia or whatever syndrome happens to plague your nursing home can be a really easy, nice place to start. Educational strategies must include nurses, patients, and their families, and I can't stress this enough, and I think there's some questions about this, but in nursing homes, nurses are very much advocating for their residents and are often driving antibiotic use, so including nurses on education about antibiotic stewardship programs is absolutely essential in the nursing home setting. And I think patients and their families as well. Patients and families are also advocating for themselves and for their loved ones and need to be educated about antibiotic stewardship. That this is not something we're limiting or we're doing something inappropriate for their loved ones, but this is actually the appropriate care so that they don't develop an antibiotic-resistant infection in the future. And lastly, stewardship programs and their interventions must be tailored to the environment. Very, very important to make sure that happens. So lastly, recommendations, partnership. I think I've stressed this a couple of times, but I really think the goal should be a standardized regional approach to a stewardship program. So this is where hospitals and nursing homes work together. And I think the three areas that a hospital can help long-term care facilities with is providing the drug expertise, improving interfacility communication, right, making sure that we talk to one another about what is happening in each facility, both at the facility level as well as the patient level, and then sharing resources, right, altruistically, how do we help each other so that antibiotic resistance doesn't continue to worsen. All right, thank you very much for your attention, and now I'm going to get into a couple of questions. So, Carlos, am I just going through the questions that you have emailed me?
Yeah, Kavita, this is Marnie.
Okay, hi.
Hi. I think one of the, if I could sum up kind of some of the questions, we have some also prepared, but some of the questions from the panelists has to do with obviously trying to match appropriate antibiotic therapy with the appropriate diagnosis. I think you talked about a little bit with the asymptomatic bacteriuria, but also pneumonias, and you've obviously got patients coming from the nursing home to the hospital. You're trying to get appropriate diagnosis, so maybe you could comment a little bit about that.
Right. So you know, it's interesting. In the nursing home, maybe 10, 20 years ago, diagnosis was really problematic because there wasn't a lot of, you know, radiological tests available, laboratory tests available. And now we've swung the other direction, whereas in nursing homes, we have actually too much information. We have too much information on what their urine cultures look like, and we are able to get some of our radiology colleagues to come in and get data for us. But I think what we see often is we see a reflexive treatment of laboratory testing because we have this over data occurring now in nursing home settings. And so what we're seeing often is we're seeing, you know, a symptom resulting in a urine culture, and then that symptom is now not there anymore in the resident. They don't have it anymore. What happens is 2 days later, the urine culture comes back positive, and then the patient is, the resident is then given an antibiotic to treat a positive urine culture. And I think the question, I think, really focuses on what is diagnosis, right? Like, how do we diagnose a UTI? It's not just simply a positive urine culture, which is, I think, what predominantly a lot of our providers in nursing homes think it is. We have to have symptoms in place as well as a positive urine culture to then make you feel that it's appropriate to give an antibiotic. Let me show one thing really quickly. So one thing that I had the pleasure of working on with the Agency for Healthcare Research and Quality was this nursing home antimicrobial stewardship guide. And the link is at the bottom of the screen. I think it's a really nice resource for you all to be aware of, especially those of you working in nursing homes. So this is a really expansive guide which incorporates lots of different projects from ARC to develop individual toolkits. And they have a couple of toolkits on communication, clinical decision-making about potential infections, and a couple on how to develop antibiograms. It's a very comprehensive guide. They have everything from how do you educate your family members on antibiotic stewardship all the way through how do you educate your providers on how to make a correct diagnosis. So I do want to mention, I don't know if I have any of the slides here. Oh, here we go. So here is the example for UTI. So this is something that, if, especially in a nursing home where you have still a paper chart, you could actually have the nurses fill this out. And you can see under the assessment and recommendation part, the assessment part actually goes through how you make the diagnosis for UTI. And we've developed these forms for 4 different syndromes in the nursing home. So this can also be a nice way to help make the diagnosis. But again, I want to emphasize that laboratory data is not enough to make a diagnosis oftentimes, especially for UTI. It has to be in conjunction with symptoms, and these type of forms can really help with that.
Well, Dr. Trivedi, thank you so much. Unfortunately, we are at the end of our webinar time. So with that, I'd like to close and thank all of our participants for joining us today. The webinar was recorded and will be available at our website, our ASP website at www.cidrap.umn.edu/ASP. Dr. Trivedi, thank you so much for your insights today into this very complex issue, and we appreciate your support.